Good morning, everybody. The topic which I'm going to be discussing is the effects of psychotropic medications on the sleep-wake cycle. This is a very comprehensive topic, so I just want to get right into it. In reference to the objectives, I'm just first going to help link the neurophysiology of sleep to neurotransmitters. Secondly, by the end of the presentation, I hope everyone can appreciate the effects of psychotropic medications on these pathways and on sleep. And finally, I'm going to give some cases where knowing the pharmacology will illuminate management of sleep disorders. There is a bidirectional relationship between sleep disorders and mental health conditions. Subsequently, a lot of the patients we see in the VA have comorbid psychiatric conditions and are taking psychotropic medications. So knowing the effects of the psychotropics on the sleep-wake cycle will definitely help treat the sleep condition also. And I'm going to go over a lot of cases. I can't tell you the number of times where someone has come into the sleep clinic complaining of insomnia. Their OSA has been adequately treated, and they've already finished cognitive behavioral therapy for insomnia. They still have insomnia, and then when I do a medicine reconciliation, I see they're taking Bupropion in the evening, which is an activating medication, and it has a stimulatory effect. So I just switch the evening dose of Bupropion to the morning, and then their insomnia has resolved. So kind of complex problem, simple solution. So it's very important to know the effects of these medications, and I'll go over more cases. The first thing I want to talk about is the neurophysiology of the sleep-wake cycle. A lot of times we just discuss the neurophysiology as an academic exercise, but I feel if we understand the neurophysiology of the sleep-wake cycle, we'll better understand how the psychotropic medications affect the sleep-wake cycle. And the first thing that I do is that I divide it into a wake system versus a sleep system. This is how I learned it, and this is how I outlined it in the presentation. So the first thing you want to do when thinking of the neurophysiology is divide it into a wake and arousal system versus a sleep system. After you do that, you want to specifically look at the neurotransmitters, pathways, and receptors involved in each system, and that's how I'm going to go about it. You're going to find that these two systems are highly interrelated and they work together, but they have distinct differences in the active processes that occur within each system and distinct differences in the neurochemical system involved in each system, but they do work together. And it's a very, very fascinating physiology. So the first thing I'm going to do is I'm going to break it down according to the neurotransmitters. The first column is the excitatory neurotransmitters: glutamate, orexin, acetylcholine, histamine, norepinephrine, serotonin, and dopamine. You really want to commit these to memory. These are your excitatory neurotransmitters, and these help modulate the wake system. And if you go to the second column, there's the inhibitory neurotransmitters: GABA, glycine, and galanin. These are the main CNS inhibitory neurotransmitters, and they're responsible for the sleep system. A few things I want to point out. So if you just look at the excitatory column, serotonin, norepinephrine, dopamine, histamine, these are wake-promoting neurotransmitters, and they help the wake system function. So anything that enhances these neurotransmitters are going to keep you awake. So if you give something like methylphenidate, which enhances norepinephrine and dopamine, it helps promote wakefulness. If you give something like Adderall, it enhances norepinephrine and dopamine, so it will help promote wakefulness. If you give something like modafinil, it increases hypothalamic histamine, it will help promote wakefulness. And then going over to the inhibitory side, GABA is the main CNS inhibitory neurotransmitter. Your sleep is really, really, really modulated by GABA. 99% of your sleep is modulated by GABA. So anything that enhances GABA will help you sleep, like something like a benzodiazepine. And an interesting point is that a lot of these wake-promoting neurotransmitters, like norepinephrine, serotonin, dopamine, they're also key neurotransmitters involved in depression. So this next slide, Dr. Schaefer came up with this conceptual theory known as the flip-flop switch, or the seesaw mechanism. And if you look at the bottom of the screen, you can see a wake switch there. So if you're paying attention, you're awake, this is what your brain looks like. So all those wake promoting neurotransmitters that I mentioned, for instance, histamine in the tubular mammillary nucleus, dopamine in the ventral tegmental area, serotonin in the raphe nuclei, norepinephrine in the locus coeruleus. These are all in the brainstem. And these neurons work together. The projections of these neurons fire in a characteristic pattern that promote wakefulness. They go through the thalamus, the hypothalamus, the basal forebrain, and then activate the cerebral cortex, and you have cortical activation. Your cortex is the largest area of the brain. So when you activate it, you're awake, you're alert, you can carry out important functions like speech and memory. So this is what your brain looks like when it's awake. And interesting enough, while your wake system is taking place, at the same time, it's inhibiting your sleep system, and that's how they work together. So later on tonight, when you go to sleep, this is what your brain looks like. And at this time, the sleep system kicks in, and your main sleep area of the brain is the ventral lateral preoptic nucleus located here. And it releases GABA. And GABA will directly inhibit all those wake promoting neurotransmitters that I talked about just a minute ago. And then that's how you sleep. But what modulates this flip-flop switch or this seesaw mechanism? I mean, how do you go from wake to sleep and then vice versa? So orexin, also known in the sleep community called hypocretin, is the stabilizer of the sleep-wake states. Orexin allows us to go back and forth between sleep and wake. So it's a very important neuromodulator. And as a side note, you know, narcoleptics who have a deficiency of orexin, they have a pathology of this sleep-wake switch. So essentially, a main symptom of narcolepsy is fragmented sleep and fragmented wakefulness because they have a pathology of the switch. Orexin also, right here, let me see if I can get my cursor, in the posterior lateral hypothalamus, it also directly activates the cortex, and it also directly activates all those wake-promoting neurotransmitters. So a very important neuromodulator. So coming back to this, so here's the seesaw mechanism. You're awake right now. Your acetylcholine, dopamine, histamine, norepinephrine are firing right now, sending a signal to your cortex, and at the same time, they're inhibiting GABA. And then later on tonight, your sleep promoting neurons, GABA takes over and inhibits all those wake promoting neurotransmitters. What's really interesting is GABA can inhibit orexin, but orexin really has hardly any effect on GABA. So these are the key players involved. So, you know, there's two ascending arousal pathways. So just, you know, referring to this figure, if you look at, I'm going to move forward a little bit to this slide right afterwards, because there's two ascending arousal systems. There's a monoamine system, which is the serotonin, norepinephrine, dopamine, histamine, and then there's a cholinergic system, which is the acetylcholine system. So coming back to that previous slide, so what's interesting is that the monoaminergic system starts at the top of the brainstem. It'll send signals to the thalamus, the hypothalamus, the basal forebrain, and then activate the cortex. The cholinergic system is also an activating system, and it will go from the pontine tegmentum to the thalamic relay area, and then activate the cortex. So these are the two main arousal systems. So the acetylcholine, it fires rapidly in wake and in REM, and it's inactive in REM. So this is very, very important, because this is the only neurotransmitter that you're going to see that's active in wake and active in REM. So, you know, it's active basically both during sleep and wakefulness. And this is very interesting, because maybe that's why, you know, when you look at the PSGs, sometimes, you know, the wake stage looks a little bit like the REM stage minus the chin tone. And the function of this arousal system is to facilitate transmission of sensory information to the cortex. And the other arousal system, which I had just mentioned, the monoamine system, it projects to all those areas, the lateral hypothalamus, the VLPO, the basal forebrain, and cerebral cortex. So it activates the cortex in reference to its function. It also inhibits non-sleep generators. You know, we talked about that. When the wake system is working, it inhibits the sleep system mutually. So it inhibits non-REM sleep generators, and it fires during wake, slowly in non-REM, and silently in REM. And orexin, of course, that's the sleep-wake stabilizer. It's located in the posterior lateral hypothalamus. It will activate the cerebral cortex. It will activate both of those ascending arousal systems. It serves as a state stabilization, and it fires during wake, and it's silent in both non-REM and REM. And our main sleep promoting system is the VLPO, located near the basal forebrain and the flip-flop switch. So the ventrolateral preoptic nucleus is the main sleep promoting center. It releases GABA. 99% of your sleep is due to GABA. It's the major CNS inhibitory neurotransmitter. Galanin is there, but it's a minor neuropeptide. It's only like 1%. And then when the sleep system kicks in, it inhibits both ascending arousal pathways, and it also inhibits orexin. So let's talk a little bit about GABA. So why is it such a powerful CNS inhibitory neurotransmitter? Well, because when you enhance GABA, you basically cause an influx of chloride ions into the cell in the outer membrane. The chloride ions have a negative charge, they hyperpolarize the cell, and they suppress nerve activity and delay action potentials. And that's why that's how GABA helps us sleep. So then you can think of benzos, which increase the frequency of chloride ion channels opening. And you can think of barbiturates, which increase the duration of the chloride ion channel opening. And that's why they help us sleep. So this slide basically shows our sleep system. It shows the VLPO, and here's GABA and galanin. And it will go directly and inhibit all those wake promoting neurotransmitters, and it will also inhibit orexin. And this slide is kind of a summary of which neurons are active in wake and which ones are active in non-REM and in REM sleep. I just put this here. Depending on your background, you might find this some utility in this slide. So I talked about the neurotransmitters. I talked about the wake promoting neurotransmitters, the sleep promoting neurotransmitters. I talked a little bit about the pathways. And now finally, I want to talk about the receptors. And this is where it gets a little bit gray. You got half the job done when you know which neurotransmitters are exciting and which ones are inhibitory, but you really got to pay very attention to the receptors. So, you know, let me go down to the histamine, a neurotransmitter. If you block H1, it promotes sleep, right? Because H1 is histamine is a wake promoting neurotransmitter. So if you block H1, it promotes sleep. I'm going to go back a little bit to the beginning. So I just want to show you, let's go over here and find histamine in the tubular mammillary nucleus. So histamine sends off a signal and it activates the cortex, and now you're awake. If you give somebody an H1 blocker like Benadryl or something like that, it will actually block the signal. So that it's blocking the signal, so the histamine signal can't go to the cortex, and that's how it works. And go back to that other slide I was just on. So that's very important. And then I'm not going to go through the whole list. I'll go through some of these receptors with some of the medications, but just so you have an idea, if you agonize alpha-2, it helps promote sleep. So something like clonidine. If you block alpha-1, it helps promote sleep, like something like trazodone. But coming back to histamine, so if you block H1, it promotes sleep. However, if you block H3, it promotes wakefulness. So that's why it's very important to understand the functions of these receptors. When you block H3, it causes a secondary release of excitatory neurotransmitters like histamine, acetylcholine, has a strong wake promoting effect. And that's how medications like pitolisant work. So this slide here is just to give you an idea that there's different types of receptors for each neurotransmitter. H1, you block H1, you get sedation and drowsiness. If you block H2, you inhibit gastric acid secretion. And if you block H3, it promotes wakefulness. So now I'm going to move forward into the meds. The first group of meds that I wanted to talk about are the SSRIs. Mainly, I picked these first because these are the most commonly prescribed medications in the world. There's literally one prescribed every 6 seconds. We all know that SSRIs increase serotonin in the synapse. They all inhibit the reuptake of serotonin. But what a lot of people don't know is that each SSRI has a secondary pharmacological mechanism of action which sets it apart. And no two SSRIs have the same secondary pharmacological characteristic. And maybe that's why some people respond differently to one SSRI compared to the other. In this next slide, essentially, what I'm just showing is how the SSRIs work. So this is your presynaptic area. And what we think happens in depression is that the serotonin is reabsorbed in the presynaptic area. It doesn't come down and bind to the postsynaptic area. So what SSRIs do, selective serotonin reuptake inhibitor, they inhibit the reabsorption so that the serotonin can come down and bind to 5-HT1A and have an antidepressant effect, and you have a euthymic normal mood. It's very interesting. There's about 22 serotonin receptors that we know about. If you stimulate 5-HT2A, it can cause sexual dysfunction, insomnia, or anxiety. The same thing as if you stimulate 5-HT2C, it can lead to sexual dysfunction, insomnia, and anxiety. So, if medications like Mirtazapine that block 5-HT2A and 5-HT2C can help treat insomnia. And I'll get into that in a few minutes. So the first SSRI that I want to talk about is Sertraline, also known as Zoloft. This is an activating medication. It has a stimulatory effect. And it's because its secondary pharmacological mechanism of action is that it inhibits the reuptake of dopamine. It increases dopamine. Now remember from the previous slides that dopamine has a wake-promoting effect. So, that's why medications like Adderall, methylphenidate, they increase dopamine and they keep us awake. So this medication has the properties of reinforcing stimulants of like Ritalin and cocaine. It's a very activating medication. So, generally when we have somebody who's depressed and they have anhedonia, poor self-esteem, they're lethargic, fatigue, low energy, we generally give them Zoloft to help perk them up because it's an activating medication. I can't tell you the number of times where I'm in the sleep clinic and I see somebody who has insomnia and they're taking Zoloft at night. So all I do is I switch it to the morning time. So this is something you really want to keep on your radar. It's an activating med and you really want to give it in the morning because otherwise if you give it at night, it can lead to insomnia or worsen insomnia. In the same breath, when patients have idiopathic hypersomnia and they're depressed, they're very sleepy during the day, they have a high Epworth score, and they're depressed also, I generally use Zoloft because it will treat the depression and provide ancillary therapy for their hypersomnolence condition because it's an activating medication. It also works on the sigma receptor down here, which is associated with anxiety and psychosis. So generally people who have PTSD is really an anxiety condition. So we generally give this medication for PTSD also. But the main take-home point is that it's an activating medication. You can remember it has a Z in it. So take it in the morning to get your Zs at night. I know that might be a little bit comical, but it's an easy way to remember it. Going to the next medication is Fluoxetine. This is the most activating SSRI you will find. It's very activating for a few reasons. One is that it inhibits the reuptake of norepinephrine. So you get a release of norepinephrine, which is a powerful wake-promoting neurotransmitter. Secondly, it blocks 5-HT2C. And when you block 5-HT2C, you enhance the release of norepinephrine and dopamine. And then it also inhibits the reuptake of serotonin, which is another wake-promoting neurotransmitter. So this medication really works on 3 neurotransmitters, norepinephrine, serotonin, and dopamine, all of which are very wake-promoting. So the same case with Zoloft. Make sure you give this in the morning. It's very activating, and I sometimes also use this in patients who have idiopathic hypersomnia and narcolepsy who are depressed because it will have some ancillary assistance in treating their hypersomnolence condition. But it's a very, very activating medication, and you can remember it has a Z in it, so take it in the morning to get your Zs at night. The next medication is paroxetine, which is Paxil. This is a commonly used medication. This is the most sedating SSRI. So this medication needs to be given at night. The reason why it's sedating is because it blocks histamine receptors, and it's also anticholinergic, and it blocks muscarinic receptors. Remember that acetylcholine is also another wake-promoting neurotransmitter. So I know some of you are looking at this triangle and seeing this NRI. So it does cause a little bit of a release of norepinephrine, but it's not that significant. Most studies show that this medication is very sedating and should be given at night. So sometimes in the sleep clinic, you know, when I'm with the fellows or when I'm by myself, you know, I see a patient and they're napping during the day and then they can't sleep at night. And then we don't want them to nap during the day because they're going to, you know, mess up their homeostatic sleep drive and they're not going to be able to sleep at night. And I see that they're taking paroxetine, Paxil in the morning. So what I do is I switch it to nighttime. So that way they don't nap during the day. The next medication is Luvox, which is called Fluvoxamine. This is the second most common sedating SSRI. Despite being the first SSRI to come out on the market, it never got approved for depression. It got approved for OCD. We use it a lot for OCD. This medication is also very sedating. The reason why this medication is very sedating is because it inhibits the degradation of melatonin. So if you see this medication and somebody's taking it during the day, just tell the psychiatrist or neurologist or whomever and consolidate the dose to nighttime so it won't interfere with their sleep. Because if it's taken during the day, again, it's like Paxil, it messes up their homeostatic sleep drive and it prevents people from sleeping at night. And you will see this medication sometimes in the VA because it's used off-label for a lot of things. Citalopram and escitalopram, these medications are neutral. They're not really associated with insomnia or sedation that much. From a clinical posture, I can tell you I've never seen these medications interfere with sleep. The only difference is that, citalopram, it inhibits the reuptake of serotonin, so more serotonin can come down and bind to 5-HT1A and have an antidepressant effect. But it has an R enantiomer, which is a stereotypic isomer of the S enantiomer, and that R enantiomer is associated with QT prolongation and can lead to arrhythmias. So it has a black box warning above 40 milligrams, and that's why they came out with escitalopram, which doesn't have the R enantiomer. Both of these meds are used for depression and anxiety, but they really don't cause too much insomnia or sedation. There is a dose-dependent effect with escitalopram that it can lead to insomnia given at high doses because it's working on serotonin, but most of those research studies have it at 80 milligrams and we don't really go above 40. So I think in terms of this, if you see this, you don't have to have it on your radar as much that it's gonna disrupt nocturnal sleep, either one of these meds. So I threw a few cases in here. So I kind of wanted to make the presentation interactive because I think it's easier if we have cases. Does anybody want to read the first case or I can read it?
I'll read the first case.
Okay.
A 50-year-old obese female comes into the sleep clinic for follow-up. Upon review of her PAP download, her more than 4-hour usage is 90%. Her AHI is 1.4 and her leak is insignificant. She reports difficulty with sleep initiation and sleep maintenance, which started 3 weeks ago, after her psychiatrist placed her on antidepressant at night. She reports her mood symptoms have resolved, but is concerned about her insomnia. Which antidepressant was she likely prescribed? At nighttime, Sertraline.
Good, very good. So I'm going to move on to the next case. Do you want to continue the second case since you did so good on the first one?
Yes, sir. After informing her of the antidepressant, which is likely the cause of her insomnia, she reports, I only take medications at night. What antidepressant can I take at night, which will likely help me sleep at night? Paroxetine. Good
job. So in reference to SSRIs, the PSG reports vary. Generally, they're known to decrease total sleep time, increase wake time, decrease REM sleep, and they've known to increase PLMs and cause PLMD. But I'm going to throw my 2 cents into this one because it really depends on the SSRI and what time you're giving it. Of course, if you're giving Prozac at night, it's going to decrease total sleep time and increase wake after sleep onset, but not so much if you give it in the morning. In reference to the SSRIs, they're associated with Prozac eyes, which are slow eye movements during non-REM sleep. But this is not unique to Prozac or fluoxetine. You can see slow eye movements during non-REM sleep with any SSRI. And they can cause frank REM sleep without atonia with or without RBD. So who's going to volunteer for the next case?
I can read it. So a 27-year-old woman comes in with a history of...
Oh, I'm sorry. Go ahead.
She reports a history of cutting her wrist 4 times in the past year in an effort to end her life. She engages in psychodynamic psychotherapy, but endorses suicidal ideation currently. You decide to start fluoxetine, Prozac. She agrees. She asks you the most appropriate time to take the medication. I would choose D, 8 a.m. First morning.
Good. Yeah, sorry to cut you off. I forgot to spell out the acronym. The BPD is borderline personality disorder. Okay. So you want to do the second one, Zach?
Sounds good. Brenda is a 28-year-old woman who is treated by a psychiatrist for symptoms of depression and anxiety. She feels tired during the daytime and often worries about how well she performs at work. She thinks that her concentration is poor. Some days she will nap if she has the opportunity. At nighttime, she has difficulty falling asleep and staying asleep. She says her mind is always too busy. She believes that her alprazolam and paroxetine help with her anxiety, but she wishes they were more effective. Since she is overweight with BMI of 29 and has disrupted sleep, her primary care physician ordered a laboratory sleep study to see whether obstructive sleep apnea might be present. Her doctor also decided to order a multiple sleep latency test since he had recently attended an educational program in narcolepsy.
And go ahead.
So her polysomnogram showed sleep latency of 18 minutes, REM latency of 165 minutes, total sleep time 380 minutes, sleep efficiency 79%. Her non-REM and REM AHI were slightly elevated, 7 and 9, and her PLMs were 15 per hour, though not associated with arousal. And her MSLT shows a mean sleep latency of 7 minutes, and looks like 1 sleep onset REM period in her second nap. Brenda's nighttime sleep study and MSLT results.
Do you want me to go back to the prior slide?
No, it's okay. I think so. I'm guessing that the answer would be D in the sense of I'm guessing what you're getting at is the paroxetine suppressing REM and possibly confounding the results of an MSLT.
Yeah, that's exactly right. You're right on.
Okay. The tech scoring Brenda's study the following day realized that both the paroxetine and alprazolam could affect her degree of sleepiness and REM propensity. It was decided that the nighttime sleep study should be repeated the following day with her offer medications. So the second test, the second day shows sleep latency 11 minutes, 3 sleep onset REM periods compared to the first test.
Okay.
I also, I think similarly, you can see with like an abrupt cessation of those medications, can see a REM rebound. So I would think the answer would be D. You have to give some time for the medication effects and the sort of weaning down effects, the REM rebound, et cetera, to wear off before you repeat a diagnostic study like that. So I would say D.
Yeah, you're exactly right. Excellent job. And you know, it's very important to taper off these medications a few weeks, like at least 6 weeks before the MSLT, if possible. So good job. Good job.
Kamal,
Yes, sir.
Could you go through this case again very quickly to reinforce that?
Sure. So
there's a lot to unpack there. So a 28-year-old, she takes her prazoline and paroxetine. She takes these medications when?
So it doesn't say when she's taking them. So let's just say she's taking them at 9 p.m. and she goes to bed at 10.
Okay, so she takes them at night. So you're sitting there and you're sitting in your PSG lab, and the pulmonary guy gets to wiggle through to a PSG and an MSLT right away, right? All right, next slide. So, are you worried about that she has sleep apnea?
So, I mean, given that, there's, if they're suspecting, there is a sleep apnea, I guess it depends on the, but I would say I'm not so much worried about the sleep apnea, given the AHI is not significantly elevated.
Well, I just think that the fake is that it's an AHI greater than 5, and I think that's a fake. I mean, hopefully somebody will realize that and stop this stuff. And hopefully somebody will figure that out. All right. Then you got periodic limb movements, right? No arousals. You got your MSLT that you talked about. Is this a good MSLT? It's only got 4 naps.
Yeah, technically there should be, I mean, there should be 5.
Yes, and your lab didn't do 5 naps, so that's good. They need an explanation. Next. Okay. So you got that. But the real thing is that, the distractors would be that she has sleep apnea and you have to repeat the study. That would be another distractor in there. Next slide. Now you got the repeat. And I think you're right. So they talk about 2 weeks being the rule of thumb. There probably is some study in the 1980s as to how long, but I don't think anybody's done it formally, but we go back. We could ask Tom Roth, why 2 weeks? It's probably so many half-lives, right?
Yeah, that's a good point. It really depends on the half-life. I mean, the half-life of Paxil is only 6 hours, so you might not need as long as time, and it also doesn't have any active metabolites. So I mean, it might, which SSRI might play a role, because something like Prozac, which has like a half-life up to 2 weeks, might require a longer amount of time to be off of it. So yeah, it definitely depends on the SSRI.
Right. Okay.
So Kingman,
Yeah.
so you made a comment that AHI of like 5 or 7 is like nothing. I think in a young woman with insomnia, that is frequently their sleep disordered breathing is causing the insomnia, and I don't think it should be blown off. It's not a degree of sleep apnea that's going to cause her to have a heart attack, but it could definitely lead to psychiatric conditions and insomnia.
Yeah. How do you figure that out in the heat of battle?
Well, the only way you can really tell is if you can manage to treat her sleep apnea and it gets better. But so what's this guy's name? I forgot this guy's name. But he took so one of the guys runs a big sleep lab out in the West.
And I know these guys are there. It's just, and you're right. We should be thinking about how to do something to get rid of those. But really what you would want to do is look at her PSG and see whether or not her flow shows any flow limitation.
Right. So, and see if it's causing arousals, if you're seeing this in like a really disturbed sleep. And, someone like this, she's not that overweight, but like an oral appliance may be something that might help her with her sleep, and positional therapy. But I would not blow off a low AHI in a young woman. I would not blow it off.
Yeah, good. Proceed.
Yeah, no, and I think that's a very good point that Denise made, because when we look at the studies, the AHI really correlates poorly to quality of life and symptom severity. So, of course, treating the sleep apnea and seeing if the sleep disturbance is resolved should be a high priority also, definitely.
And one more comment is that young women with like insomnia most of them do really poorly with CPAP. We don't have good treatment for this stuff.
And it's, you know, and I think, you know, it's, these are messy cases. I took this case from the VA. And the issue is that, you know, a lot of times we got to tease out, you know, the medications, because both the alprazolam and the paroxetine both block REM. So she could have got REM rebound when they took off the medication, and they both cause significant sleepiness. And, you know, so and then of course, you know, an extra nap would have, you know, so it's a pretty messy case, but it's, you know, something that I think that, you know, definitely looking at the sleep apnea, the medications. So these are complex, you know, cases, and these are what we usually see, and it's important to tease them out, like all the different aspects, like Kingman said. Shall I move forward, or any thoughts on the case?
Good, go ahead.
So, okay, so I think this is the last question, Zach, from the case.
Periodic limb movements in the PSG are likely associated with the paroxetine.
Good. Okay.
Yeah, but Denise would say they're probably microarousals from upper airway resistance.
That's a possibility too.
All right, keep going.
So the next question, I mean, the next medication is mirtazapine. This has a very complex but interesting pharmacology. I'm not going to spend so much time on it because we could spend the whole presentation on this med, but it's something you want to keep on your radar because it is prescribed quite often. And this medication, how it works is a presynaptic alpha-2 blocker. So over here, so when you have alpha-2 receptors on the serotonergic and noradrenergic neurons, they kind of hold, you got to kind of visualize it like they're holding the serotonin and norepinephrine above the synapse. So when you block those presynaptic alpha-2 receptors, you cut those brake cables and you cause a surge of release of norepinephrine and serotonin. And that's how it treats depression, around 30 milligrams. But what I really want to hone in on this medication is that this is generally a sedating medication. Have that in your mind. And more importantly, this is the only medication that I have come across that the lower the dose, the more sedating. This medication comes in 7.5, 15, 30, 45, and 60 milligrams. Now, the lower the dose, the more sedating. It's an antihistamine. It has antihistaminergic properties at all doses. However, the higher you go up on the medication, it starts to release norepinephrine because it blocks those alpha-2 receptors, and that's usually at, you know, 45 milligrams. So there's always a knee-jerk reflex, like if somebody's on trazodone 50 milligrams and it's kind of working, it's working halfway through the night to help them sleep. Then what you decide to do is you might go to trazodone 100 milligrams. But with mirtazapine, if somebody's on 30 milligrams and it's partially working, you're going to decrease it to 15. So you really want to keep in mind that, you know, this medication, the lower the dose, the more sedating. It really blocks histamine significantly. A lot of times, you know, if somebody's taking 7.5 at night, they'll sleep, but then they'll tell you, hey, I'm sleeping through the night, but I have this next day residual sleepiness, and then I'll move them to 15. And then usually they're okay. But if they're not okay, they'll still be sleeping through the night at 15, then I'll move them to 30. So remember, the lower the dose, the more sedating. I can't tell you so many times I've been in sleep clinic and somebody is taking, you know, I'll get a referral for narcolepsy and they're taking mirtazapine 7.5 milligrams in the morning. So you really need to watch out for this med. So the clinical points in depressed patients, it's been shown to increase your sleep efficiency, increase your total sleep time, and reduce your sleep latency. And this medication doesn't significantly alter REM sleep too much. I think because, you know, a lot of times it's prescribed at 30 milligrams and it's not working too much on serotonin at that dose. There have been studies where bedtime dosing of 15 milligrams of mirtazapine impaired next day road tracking, but that usually went away after 9 days. So the point they're making is that at lower doses, it might be extremely sedating even when you give it at night. So you still have to adjust the dose. So here's the first question. Can somebody volunteer?
Sure. The patient complains of insomnia, sleeping 2 hours a night, and depression. You decide to prescribe mirtazapine at bedtime Which dose is likely to help him fall asleep? 7.5 milligrams.
Good. And then here's a spin-off of that question.
The same patient comes back 3 days later and says, Doc, I'm sleeping 7 hours a night, but feel tired all day. You made me feel like zombie. I have wedding to go in 5 days. What is the next step? So in the lower doses, it is sedating. In the medium to high doses, it treats the depression. Looks like he feels zombie, so why don't he take 7.5?
This is a very
yeah,
very tough question.
7.5 milligrams in the morning.
Okay. So let's go back to the first question. You gave him 7.5 milligrams. So I should have, you prescribed it at bedtime. So you give him 7.5 milligrams at bedtime. And then he's sleeping through the night, which is good, but he has this next day residual sleepiness, this carryover effect from the med. So what you probably want to do is increase the dose to 15 and see how that goes. The lower the dose, the lower the dose, the more sedating. So you could put him on 15 and see how he does. And then if he's doing okay, he's out of the woods. But if he still endorses, sleepiness the next day, you can increase the dose to 30 milligrams. If you gave him a dose of 45 or 60 milligrams, it would really release norepinephrine, and it would be an activating medication. So the take-home point with this is just remember, like, the lower doses are more sedating, and if you give somebody a high dose like 45 or 60, it's not going to help them sleep because it's going to be working on more norepinephrine. Does that make sense?
Sure. So at that moderate dose, 15 and 30, it should be both sedating as well as treating depression.
Yeah, at 30 milligrams is usually a good balance. That's a really good question. The majority of patients I have on mirtazapine are on 30 milligrams because it's blocking histamine, but it's also starting to release norepinephrine and serotonin, which are wake-promoting neurotransmitters, and it combats that next day residual sleepiness. So there's a good balance. So the majority of patients, I say about 90% that I have on this med are taking a dose of 30 milligrams. Yeah, good point.
Thank you.
Okay, and anyone, you want to do the last question? Sure.
A veteran comes into the sleep clinic and reports he may have narcolepsy and would like a stimulant. Upon medicine reconciliation, you notice that he's taken a mirtazapine 30 in the morning. He reports the current dose of 30 is adequately treating his depression. What's the next step in this management? I would change it to bedtime.
Exactly. Yeah. So, and you'll see this a lot, particularly in the VA. So it's good to have this med on your radar. Okay. The next group of meds which I want to discuss are TCAs. I didn't put too many slides on TCAs because I don't see them too often, but neurology prescribes them a lot for headaches. So I wanted to put a few of them in here. So these medications are really 5 drugs in one. They block histamine, they block alpha receptors, they block muscarinic receptors, and they inhibit the reuptake of serotonin and norepinephrine. So they're really 5 drugs in one. They'll block histamine, alpha, muscarinic receptors, and they'll increase serotonin and norepinephrine. This group of meds is probably the easier one to kind of remember because you don't have to remember too much about receptors. You just got to know which class the meds are in. The secondary amines are the more activating medications. Disipramine, nortriptyline, protriptyline. I just remember DNP. The reason why they're more activating is because they work on more norepinephrine than serotonin, and they don't really block histamine or muscarinic receptors that much. So those are your activating ones. If you go to the table on the side here, let me find disipramine. Its selectivity for norepinephrine is very high, so it's a very activating medication. And it doesn't work on serotonin that much, and it's not that anticholinergic or antihistaminergic. The tertiary ones, amitriptyline, clomipramine, imipramine, doxepin, trimipramine, These meds are more sedating because they have anticholinergic and antihistaminergic activity. And in addition, they work more on serotonin than norepinephrine. So you can kind of figure out the effects that it'll have on sleep just by which class it's in. So the sedating ones are more likely to have a positive role in restoring sleep architecture. They do suppress REM sleep because they do work on serotonin. They'll shorten sleep latency. They'll reduce wake after sleep onset, and they appear to have some efficacy in short and long-term insomnia. And then the tertiary one, the tertiary ones are the ones that will do those. The secondary ones will have the opposite effect. I'm not advocating to give these meds for insomnia in any manner. What I'm advocating is, like, sometimes I'll have somebody come in the sleep clinic and they're having difficulty sleeping at night. If they are taking a secondary TCA like disipramine, nortriptyline, or protriptyline, I'll make sure they're taking it in the morning. So this chart is the TCAs and their Ki constant, which is the affinity towards the receptor and the function. Now, the lower the number, the higher the affinity. So a good measuring or a good metric number to use is 20. So anything below 20 has a good affinity towards that receptor. So let's just do 1 or 2. So disipramine, it's 0.83. So it's a very, very low number. So it has a high affinity towards norepinephrine. It causes a lot of norepinephrine release. And then if you go to the histamine, it's above 20, it's a high number, so it really doesn't block histamine that much. And it has a high number for muscarinic receptors, so it's not really anticholinergic. So it really just increases norepinephrine, so it's a very activating med. One thing I wanted to mention is I had one of my former chairmen, he had a patient that was significantly depressed. They were lying in bed all day, sleeping all day, anhedonia, poor self-esteem, had suicidal ideation, and he prescribed the patient disipramine. 2 days later, we saw the patient in the ER, and then we asked him, hey, what happened? He said, well, you know, the doc gave me that medication, and I felt so energetic, I actually had enough energy to attempt suicide before I did it. So sometimes the energizing effect of this med kicks in before the antidepressant effect. It's a very, very activating medication. If we look at one of the tertiary TCAs, let me find one like amitriptyline, which is used often by neurology. If we go to the H1, the histamine, it has a low number, so it blocks histamine significantly. And so it causes sedation. It has a low number in the M1 column, so it's anticholinergic, it's less than 20. And if you go over here to the norepinephrine, it has a high number, so it really doesn't cause that much release of norepinephrine. So this is a sedating TCA. So I threw one question out here. Anybody want to tackle it?
Which 2 TCAs are likely to lead to insomnia if given at night? At night. Doxepin and protriptyline.
So that's a really good guess. Protriptyline. So I'll go into doxepin in a few minutes, but let me go back here. So doxepin. Okay. So I should have went over this one too. I left the chart here for you guys for reference. So doxepin, it has a low number for histamine, so it's very sedating. Its potency towards the histamine receptor actually is 100 times greater than any other receptor. So it says a low number, and it has a number above 20 for norepinephrine, so it doesn't really release too much norepinephrine. So doxepin is a sedating medication, and it's they actually recently, a few years ago, FDA approved it for insomnia. So the answer would be disipramine and protriptyline. A good way to remember this one is just if you can remember the acronym DNP, disipramine, nortriptyline, and protriptyline, you'll realize that those are the activating TCAs. And you might come across this in the sleep clinic because a lot of times neurology uses these medications a lot. So just, keep them on your radar.
No, I got it. Okay, I just read the question wrong in my head because these would. No. So doxepin would treat insomnia if given at night.
Yes, exactly.
Okay, sorry, my bad.
No,
And
you're
then,
good. You're good. You're good.
okay, yeah.
So speaking of Doxepin, so I put this in here. This is the only FDA-approved medication the only FDA antidepressant approved for sleep. None of the other medications are FDA approved for depression that I mentioned in the presentation. So this medication, if you look at the chart, histamine, alpha, muscarinic, norepinephrine, and serotonin, if you give a low-dose Doxepin, 3 or 6 milligrams, it's a multifunctional drug at a different dose. It has a different function. If you give 3 or 6 milligrams, it only blocks histamine. So it's just an antihistamine at 3 and 6 milligrams, and it's used for sleep maintenance insomnia. So, this is so in the VA, we have this. I'm pretty sure they obviously have it at UH. So they do use Doxepin low dose for sleep maintenance insomnia. And the reason why is because at low doses, it's not an antidepressant. It will only work on serotonin and norepinephrine at doses of 150 to 350. So those are the antidepressant doses, but 3 and 6 milligrams, it's just an antihistamine, and that's why it's used for insomnia. One question I commonly get is, well, in the VA, we don't have 3 or 6 milligrams in the tablet form, so I give 10 milligrams. And if you look at the receptor binding profile, like the granular details with this med, it's an antihistamine up until 25 milligrams. So sometimes if 10 milligrams is partially working when I give it to them in the VA, and I'll increase the dose to 20 milligrams because it's still an antihistamine. The higher you go up on this med, regardless, it's going to be sedating because it's a tertiary TCA. However, it's good to know that up until 25 milligrams, it's an antihistamine. If you go above 25 milligrams, then it becomes an anticholinergic. You get dry mouth, urinary retention, tachycardia, those things, constipation. So, you can, based on the clinician, you can go up to 25 milligrams, and it'll just be an antihistamine. And that's very important because one time, a pharmacist came up to me, or they contacted me on Skype, and they said, you gave 20 milligrams of Doxepin. And they said, are you worried about narrow angle glaucoma? And I told them I sent them a research paper showing it's not anticholinergic until about 25 milligrams. So it's good to know the receptor binding profile. Just a few key points about this med. It's relatively rapidly absorbed. Its half-life is a little bit over 15 hours, and there's limited potential for residual daytime sedation. But you want to take this med on an empty stomach because if you eat a heavy meal with this med, it will delay the absorption of the medication and have a carryover effect the next day. In reference to antipsychotics, I wanted to talk a little bit about them also. And so with this graph here, with antipsychotics, what I want you to have in mind is that they're all sedating, but the question is, to what degree are they sedating? That's the main thing you kind of want to think of. Olanzapine is very sedating because it blocks histamine significantly. This graph shows how antihistaminergic are these medications. So olanzapine is very antihistaminergic, is very sedating. Clozapine is also very sedating. Now, I know that you guys don't see these medications too often, and it's hard to remember the names, but a quick way to help you if you do see these meds is that if you can just know which ones are antipsychotics, any antipsychotic that I'm going to show you on the next slide is sedating if the dosage is bigger or greater than, if it's 50 milligrams or more, then it's sedating. With the exception of olanzapine, that's always going to be sedating because it blocks histamine so much, and the exception of ziprasidone because it blocks 5-HT2A and that causes a release of norepinephrine. But in general, with the exception of olanzapine and ziprasidone, most of the antipsychotics that you see in clinic that if a patient is taking are going to be sedating if they're above 50 milligrams. If they're not above 50 milligrams, they're really not that sedating and not going to interfere too much in the person's nocturnal major sleep period. So with this table, for instance, chlorpromazine, it's above 50, so it's going to be sedating, the dosage. The high milligram, low potency ones are generally the sedating ones. So with fluphenazine, it's a high potency, low milligram. So it's less than 50. It's not that sedating. The same thing with Halidol. It's not that sedating. The same thing with Abilify. It's not that sedating. Clozapine is more than 50, so it has marked sedation. Olanzapine is the exception because it blocks histamine, so it's just a sedating med in general. And then Quetiapine. I do want to mention something about Quetiapine. So a lot of times, some primary care doctors or neurologists or psychiatrists, they use, and pulmonary, they use low dose Quetiapine off label for sleep. And the Quetiapine is kind of like Mirtazapine in the sense that it's a multifunctional med. So the issue is at 25 to 200 milligrams, it's just an antihistamine. So it just blocks histamine. So that's why you see sometimes the patient's on 100 milligrams of Quetiapine and the person's using it for sleep, or 150 milligrams of Quetiapine. From 200 to around 400 milligrams, it inhibits the reuptake of serotonin. It's an antidepressant and it's used for PTSD. Not until you get to 400 milligrams does it block dopamine, and then it's an antipsychotic. So that's why for schizophrenia and bipolar disorder, the starting dose in most journals say 400 milligrams because it starts blocking dopamine at 400 milligrams. So Quetiapine at low doses is just an antihistamine, but you still have a 10% chance of getting metabolic syndrome using doses of 25 to 200. Okay, I just wanted to throw that out there. And then risperidol is if we go here, it's a low milligram med, so it's not that sedating, it's less than 50, and then ziprasidone was the other exception. So with the exception of ziprasidone and olanzapine, generally any antipsychotic less than 50 is not going to be that sedating. And I just want to mention that's important because sometimes you see a lot of psychiatrists using antipsychotics off-label for depression, and if somebody's taking a hypersomnolence condition, somebody has a hypersomnolence condition like narcolepsy or idiopathic hypersomnia, that can be a cause of concern. I just want to briefly talk about the SNRIs. I'm just going to mention the salient points. I put some extra information here for you to have for your reference. Venlafaxine works on serotonin and norepinephrine. And the key point here is that when you go above 150, it starts to increase norepinephrine. So if this medication is at 150 milligrams, you want to make sure the person is taking it during the day, because at 150 milligrams, it's stimulatory, it works on norepinephrine. We titrate this medication from 37.5 to 75, 115, 150, going up to 225, because 225 is a therapeutic dose. But when I'm titrating the medication up, I tell the patient, hey, listen, once you get to 150, you got to start taking it in the morning, because it's going to start having an activating effect. So keep that in mind. And then the logic with desvenlafaxine, it's an active metabolite of venlafaxine. What they're postulating is that when you get to around 225 milligrams of venlafaxine, some of it gets converted in your blood with an enzyme CYP2D6 into desvenlafaxine, which has a more noradrenergic focus. But the concern was that if somebody's taking a CYP2D6 inhibitor like cimetidine, the venlafaxine won't get converted to desvenlafaxine, or if somebody has a genetic polymorphism of this enzyme system, there might not be a conversion. So they came out with this newer medication a few years ago called desvenlafaxine, which is Prozac, and that just predominantly works on norepinephrine. Both venlafaxine and desvenlafaxine are activating meds. Venlafaxine at 150 or above, make sure it's taken in the morning. Prozac, since it predominantly works on norepinephrine, any time of the day, anytime it's prescribed, it should be given in the morning. It should never be given at night, because it really hones in on norepinephrine. One thing I want to say is that these medications, particularly venlafaxine, is notorious for causing periodic limb movements. I had a patient in sleep clinic one time that I was suspecting PLMD. I did an in-lab study, and I saw a high PLM index with arousals, and then I switched him off the venlafaxine to bupropion. So venlafaxine is notorious for causing PLMD, so you want to keep that in mind. And then the other take-home message is to make sure both of these meds are given in the morning to prevent insomnia. Diloxatine, the only thing I want to mention about this medication is that it's just like venlafaxine. The higher the dose, the more likely it's going to work on norepinephrine. It's a commonly used medication for depression and pain. So the issue is that if you go above 60 milligrams, please make sure it's taken in the morning. They have done a lot of studies on this medication, and most studies show that at 60 milligrams, it really starts to work on norepinephrine significantly. Okay. And it's been known to decrease REM at low doses and high doses. Milnasapram, this is the last SNRI I want to discuss. It's not FDA approved for depression in the US, it is in Europe, but it is FDA approved for fibromyalgia in the United States. This medication has, out of all the SNRIs, has the highest affinity for norepinephrine. Its ratio to norepinephrine to serotonin is 4:1. So you really want to make sure that you give this medication in the morning. It's used for fibromyalgia because it has such a strong affinity towards norepinephrine. Norepinephrine is a key neurotransmitter in the brain and spinal cord, and it's known to suppress pain signals, and that's how it got FDA approved for fibromyalgia. But I have seen this in the VA a few times, so make sure if somebody is taking this medication and they have insomnia and you see it at night, just switch it to the morning time. The last medication which I want to discuss is Bupropion. This medication is the most activating antidepressant next to disipramine. This medication is very activating because it works on dopamine and norepinephrine. It releases both of these key neurotransmitters. This is a very helpful medication in the sleep community because it's the only antidepressant that does not cause REM sleep behavioral disorder because it doesn't work on serotonin, so it's not going to cause RBD. It's not going to cause RLS. It's not going to cause periodic limb movement disorder. So this is a very good medication in that sense. The bad part about this medication is that it's very activating. So you got to make sure that it's taken in the morning. With these graphs here, what I want to kind of hone in on is, and they've done a lot of research on this, is that it comes in 3 different formulations: the immediate release, the sustained release, and the long-acting or XL release. Now, the issue with this is that the XL formulation is the one that's least likely to cause insomnia. All these formulations have to be started in the morning, but the XL formulation is the one that's least likely to cause insomnia because it has 1 plasma peak, and then after that, you take it in the morning and it has time to leave your system by nighttime. So the Tmax is the time it takes to reach the peak plasma concentration, and the Cmax is the maximum concentration in the blood. You take this, like let's take one example, like the immediate release. So you have to get, all these are based on a 300 milligram model. The immediate release formulation, which was the first one to come about, that one you take it 100 milligrams 3 times a day. The time to peak is 2 hours. So let's say you started at 8 o'clock. So you take it at 8 o'clock, it'll peak at 10 o'clock. That's the first dose, and then it'll go down, it starts to leave your system. Then your second dose is at 12, it'll peak at 2, and then it starts to come down, and then your last dose is at 4 p.m., and then it peaks at 6 p.m. And since this medication works on norepinephrine and dopamine, it's very energetic, you get pumped up in the evening time. So, it takes time for your body to ramp down. So this is associated with insomnia. The SR formulation is a little bit better. It's based on still the 300 milligram model, but this time you take 150 twice a day. The Tmax is 3 hours, so it peaks after 3 hours. So the issue is that you take it at 8 o'clock, it'll peak at 11 a.m. Your next dose at 12, it'll peak at 3 p.m. So you have time during the rest of the day for the medication to get metabolized and broken down. But, if somebody, I see a lot of psychiatrists accidentally giving this starting at 12. So if you give it at 12, it'll peak at 3 p.m. and then your next dose at 4, it peaks at 7 p.m. and then the person is activated in the evening. So that's why I like the XR formulation, because it's a one-time dosing of 300 milligrams. Its Tmax is 5 hours. So if you give it at 8, it'll peak at 1, and then for the rest of the time, then after 1 p.m., it slowly leaves your system after that, so it's very low in the evening time. So that's why the XR formulation is the best one in terms of not having not causing insomnia. So these peak plasma concentrations are associated with both insomnia and seizures. So in summary, I just want to say insomnia is highly affected by psychotropic medications. Only use psychotropic medications in cases of an underlying mental health condition. Wellbutrin is the most activating antidepressant, followed by Prozac, Fluoxetine, venlafaxine, Sertraline. In reference to the TCAs, the secondary amines are the most activating. Antipsychotics, high milligram, low potency antipsychotics are sedating with the exception of olanzapine and Geodon. Doxepin is the only antidepressant FDA approved for sleep. And mirtazapine is sedating at doses of 30 milligrams or less. And I kind of have a cheat sheet here you can use as a reference. Any questions?
Terrific.
Where is this lecture being recorded? Sorry.
This lecture, I'm at home. It's being recorded at home. Is that your question?
I mean, no, I mean, how can I access this recorded lecture? It was so good. Thank you, Dr. Gandotra. I would like to go over it again.
Yeah, it will be available in about a week on the YouTube channel. We'll let you know.
Okay, thank you, Eric.
Yeah.
So hopefully, if I can come back again, and I want to give another presentation on FDA approved meds for insomnia, and you know, so because there were some medications I couldn't put in the lecture just for the interest of time, but you know, hopefully I can come back again soon and give another talk on expanding on this.
Oh, it's terrific. You know, this is an area which I think is a blind spot for a lot of programs.
Thank you, Dr. Gandotra. I mean, I come from a very small family medicine program and we did not have a psychiatrist in town. So if we would see patients, they were started on medications by their primary care. And I saw a lot of these problems that you were talking about and I just never thought about them. So today was like an eye-opening lecture. Thank you.
Oh, no, my pleasure, my pleasure.